So there are multiple factors that contribute to the outcomes after PCI. They include patient characteristics such as age, sex, comorbidities, a patient's clinical presentation to the cath lab, whether it's ACS or stable coronary disease, the characteristics of the patient's coronary anatomy and their lesions, nuances of the intraprocedural management, including choice of axis, pharmacotherapy that's delivered, the use of mechanical circulatory support, complications that can occur in the setting of PCI, and then the degree of medical therapy that's instituted post-PCI. And over the years, female sex has been identified as affecting many of these factors, and it's led to the understanding that women may be at a higher risk for adverse outcomes after PCI. So it's long been recognized that there are sex-specific differences in the clinical characteristics of patients who present with obstructive coronary disease. So you can see here, this is an analysis of almost 33,000 patients who were pooled from 21 randomized PCI trials. And you can see that women were more likely to be older at the time of their presentation for PCI, and they had higher rates of hypertension and diabetes. We know that advanced age and diabetic status have all been associated with worse outcomes after PCI. And in addition to differing rates of comorbidities between the sexes, women often present with more atypical symptoms as well, and this can affect their downstream care. So in this study of 450 patients who presented with a STEMI in Sweden, women were significantly less likely to present with classical chest pain and more likely to present with fatigue or nausea. And now these differences likely contributed to women having a significantly longer delay from time of symptom onset to first medical contact. And then there was a subsequent trend towards a longer time to diagnosis once the patient actually got evaluated by a medical professional. And this is likely partially due to the fact that neither the patient or the medical provider clearly attributed their symptoms to a cardiac cause. Beyond patient characteristics, there's sex-specific differences once the patient makes it to the cath lab. While radial access has been shown to substantially reduce the risk of bleeding and vascular access complications compared with femoral access, these effects may be more pronounced in women. So this is a subgroup analysis of the RIVAL trial. RIVAL trial randomized almost 7,000 patients to PCI with either a femoral or a radial approach. They found that major vascular complications were significantly reduced with the use of radial access in both men and women, but that benefit was larger in women with the number needed to treat of 33 as compared to 49 in men to prevent one vascular complication. And despite these findings, those studies have found that women may be more likely to receive femoral access than men, thereby putting them at an exaggerated risk for vascular complication and bleeding. Now, arterial size is often cited as one of the reasons when radial access is not used in women, and this size issue translates to the coronaries as well. So multiple studies have shown that women have smaller and more tortuous arteries, and this can certainly contribute to the higher rates of periprocedural complications that's seen in women who are undergoing complex PCI. So shown here are two studies evaluating sex differences in periprocedural complications in patients undergoing either rotational or orbital atherectomy. You can see that coronary dissection was significantly higher in women in both studies, and one of the studies found that there were higher rates of tamponade and coronary perforation as well. So it's not surprising then that these sex-specific differences in patient characteristics, in presentation, in anatomy, and procedural complications have all led to sex-specific differences in outcomes. So this is a study of almost 9,000 patients who presented with STEMI between 2010 and 2016. And you can see on the left, in every age group, unadjusted analyses show a higher 30-day mortality for women as compared with men. And even after multivariable adjustment for comorbidities, treatment covariates, all those sorts of things, women under 60 still had a higher early mortality risk than men of the same age category. Now, this age paradox is interesting. That's also been seen in this study here involving the NHLBI registry. So this study evaluated the association of sex and age on cardiovascular outcomes in patients who are undergoing PCI for both stable and unstable coronary disease. And again, after adjustment for other covariates, women under the age of 50 still had a significantly higher rate of MACE, predominantly driven by a need for repeat revascularization at 5 years. However, when you compared it with men, you could see that there was no effect of the sex when seen in patients over age 50. Now, there is some conflicting data as to whether sex-specific differences are confined to the short-term period after PCI. Some studies have suggested that female sex remains a risk factor even for long-term outcomes after PCI, although most of the data does suggest that long-term outcomes are generally similar with the exception of younger women, as I noted earlier. So this is pooled data of 9,700 patients who were treated with drug-eluting stents with 10-year follow-up. And on the left, what you can see is that women had an increased risk for repeat myocardial infarction within the first 30 days, and most of those events were occurring within the first 48 hours. But after 30 days, there was no significant difference in MI rates out to 10 years. And additionally, there was no significant difference in cardiovascular mortality out to 10 years between the sexes. That said, we all know that not all PCI is the same, and in particular, complex PCI is known to be associated with worse short and long-term outcomes. So this is a study from the WIN-DAS database of over 10,000 women who underwent PCI. And you can see here that women who underwent complex PCI had a significantly greater rates of MACE. This was defined as a composite of all-cause mortality, myocardial infarction, or target lesion revascularization. And they also had higher rates of death, MI, and stent thrombosis out to 3 years. So in conclusion, women represent a patient group that's at higher risk for adverse outcomes after PCI due to a combination of clinical, procedural, and systematic factors. This risk is particularly enhanced in young women and women who are undergoing complex procedures. And there's a real need for increased awareness of sex differences in the presentation of coronary artery disease, as well as research to guide sex-specific recommendations for patients undergoing PCI in the current era. Thank you very much.